Hello, good evening, good afternoon, good morning, good night, good day, wherever you are in the world, and welcome to the Black Belt Academy of Surgical Skills. My name is David O'Regan. I'm a cardiac surgeon in Yorkshire in the United Kingdom. I'm also the director of the Faculty of Surgical Trainers for the Royal College of Surgeons of Edinburgh and now a visiting professor at Imperial College London. Thank you for joining us if this is your first time, and welcome back if you're returning. I'd like to say a particular thank you to Vlad, who sent me pictures of his practice of knot tying at depth and of his banana exercises. Please keep your pictures coming in. I'd like to see your practice, and what you're doing looks fantastic, and thank you very much indeed. This evening, we want to talk about bringing it all together, and I'm referring to closing wounds. Now, closing wounds is often referred to colloquially as coffee time, and everybody leaves theatre, and the most junior person is left to close, and everybody is tapping their watches saying, come, come, come on. But it's the wound and the final scar that the patient sees. And it's the way and technique that you use to close the tissues that determines the success of the operation. And I've always felt it's rather silly of us to leave the most junior person in theatre unsupervised to close wounds without instruction, without practice. So this evening, I'd like to bring what we've discussed before about needle handling, rotation, tissue handling, and bring that all together with a focus on how to get the best out of closing your wounds. Now, you need to understand some pathophysiology of wound healing before we start. Whenever we make an incision and close, there's going to be bleeding, and clotting is the first stage of any healing. And thrombin is a very, very powerful inflammatory agent that actually calls all the other cells in to help. But thrombin also causes pain. Too much thrombin also causes too much of a response. And the whole of your pathogenesis of healing is a balance between just enough, too little, or too much. So the bleeding and the clotting fills the gap immediately. And you see that on the wound with a scab on the top. And that's in minutes. And within days, then you see an inflammatory reaction because the thrombin is called in, the mast cells, macrophages, and everything starts. A big milieu of inflammatory juice stimulating fibroblasts, stimulating angiogenesis, and this inflammatory stage is not only clearing up debris, but setting the stage for healing. But the inflammatory stage, as you know, when you bruise, involves a lot of fluid coming in. With that fluid comes swelling of the tissue. And all the tissues will swell for a period of time over a few days before settling, as you know, with a bruise. And when you look at a bruise, do bear in mind the color changes from purple, blue, to green, to yellow, to brown, as the hemoglobin is broken down. So following that inflammatory phase, then you've got a proliferative phase of growth of new tissue, angiogenesis, growth of fibroblasts, and the skeleton of the tissue is starting to pull together. But of course, we also know if that is too much, you get that granulation tissue. And that granulation tissue can persist because of persistent inflammation or nidus infection, and the granulation tissue can become quite proliferative itself. And after a few weeks, then we go into months of rebuilding. And the myofibrils start to cause the thing to contract. and the collagen is laid down and the wound is brought together, and over months, if not years, in some cases, in some tissues, it starts to strengthen. So basic knowledge of how long it takes in each of those stages is required in your thinking in closing the tissues. Now, we close with sutures, and the suture material is either natural, and catgut and silk have been used for time immemorial, even from the Roman ages. And when I started surgery in 1987, my consultant, Mr. Southwood, he used to insist on closing the skin with black silk sutures. And I would say, Mr. Southwood, please, you must be tired. Go and have a cup of tea, and I'll close for you. And I'd pull out an absorbable synthetic material to avoid the inflammatory reaction that we see with silk. But when we think about it, we use silk to tie in all our drains. But silk itself is very inflammatory. Then we got permanent and absorbable. And it was in 1969 that Johnson & Johnson brought out polypropylene and Prolene that we know. Then there's the absorbable PDS sutures that are polysaccharides. And in 1974, they brought out a Vicryl, an absorbable suture, which is dyed or undyed, but the dye itself can also leak into the tissue. But the theory also is braided sutures, which are not like, unlike string silk, can cause damage themselves and carry bacteria in because of all the nooks and crannies within the suture. So some people actually say, forbid using a braided suture in closing layers and prefer to use a monofilament. But it's important that you also understand how long it takes for tissues to heal, because your choice of your suture is going to determine by how long it takes to heal. Skin, 1 to 2 weeks. Subcutaneous tissue, 2 weeks. Peritoneum, 4 to 10 weeks. A bowel anastomosis, 2 to 3 weeks. Ureter, 1 week. And a ligament, 6 weeks to heal, but up to a year to get that tensile strength back. And of course, in vascular surgery, we need watertight, blood tight immediately, but it's going to take 4 to 6 weeks for the endothelium to shape over that. And if there's any irregularity there, that too is going to cause potential anastomotic strictures. But what is interesting when looking into the subject, people have thought closing the abdomen is the first rite of passage for a trainee closing wounds. I can close an abdomen. Well, what's interesting, there's no evidence to what suture material is the best way. In fact, there's a match 2 study and a heart study that are looking at the best ways to close. Interrupted sutures, continuous sutures, absorbable, permanent. But what they all conclude, it is your technique that is absolutely important, and attention to detail that determines how well things heal. So I'm going to take you over to the webcam, and we're going to chat about some of these principles and how you can apply them to closing the wound. And it's attention to the smallest detail every time. So I'll bring you over the top. And of course, my favorite model, as you know already, is the banana. So let us just think about this banana skin here. And let's just think that represents a layer. And I've got an incision in that layer. On either side of this incision, whether it is skin or any other layer, that inflammatory phase is going to give you what's called this lag zone of inflammatory tissue and response in that area. And that is going to swell. And if your sutures are too tight, they will cut out because of that swelling. And that is why your sutures should be spaced beyond the lag zone. So closing is beyond the lag zone. Now, the ratio of how close you put them together and the length of the suture is described as 4:1. 4 times the length of the wound is required for the length of the suture, because you need to be going beyond the lag zone, which is up to 1 centimeter, and 1 centimeter apart, all the way down, beyond the lag zone and 1 centimeter apart. And each stitch needs to be pulled together carefully and deliberately. So if you look here at what I've done with this banana, and Charles sent a beautiful picture of a stitched banana. This is a continuous suture. It then needs to go in at 90 degrees, out at 90 degrees, over and over. And there's a little bit of slack in there, because you can see if I pull it too tight, it starts to tear the tissue there. And in fact, I often see people do, thinking they're being clever, they put a suture in, and they think they're saving time, put another suture in, and pull it through. We're ready to go for the next one. Take the suture through without placing each one, and literally pull it like that. You see what's happened there? What happened there is that first stitch cut out. That second stitch started to cut out. And if you do that and go over and over, and I see it often pulling 3 times, 4 times, and then there's a deliberate pull. And the tension in that first suture cuts out, more there and less. So every stitch needs to be placed through, and the idea is to bring tissue apposition and not strangulation. And there needs to be a little bit of slack on each of these because of that lag zone and that inflammation and swelling that's going to happen. And this is particularly true in paralyzed patients, because you're dealing with very relaxed tissues and there's no tension in the abdomen. And you can see that is actually cut out. And it's always interesting to look from the inside as well to see what's happened. Subcutaneous tissue is difficult. And the subcutaneous tissue of the front of the abdomen and the deep membranous layer, Scarpa's fascia, after Antonio Scarpa, an anatomist in Italy, and then Campus fascia is the fatty layer beneath the dermis. But if you put a continuous tissue in fat and it's soft and friable, particularly in the elderly, and look at my continuous suture here, and I'm trying to stitch a banana, and I see people put continuous sutures in and pull it, and it just pulls out. There's no point doing that, because this continuous suture actually strangulates and tears the tissue. And to be honest, a purist would say the best stitch to do that is non-strangulating is a simple interrupted suture. In at 90 degrees, out at 90 degrees, tie it and you get natural eversion. Mattress sutures are sometimes quite useful, but you can see in a vertical mattress suture, which is going further out, and then in at the edge, out at the edge, you can see in this banana how it's browned at that point. And that browning is ischemia of the tissue. This is a horizontal mattress. In, out further along, in, and that's good for holding tissues together, but this itself is strangulating as well. So you've got to bear in mind that you do need a blood supply to support the tissues. And when it comes to the skin, we need to evert the skin. And when closing, not see any beveled edges whatsoever. It's always interesting to look at your stitching from the inside to see how it holds. And you can see there how the mattress suture has not done very well, or the vertical mattress suture, but the horizontal is respected. The simple interrupted suture has respected the tissue and maintained that position. So if you think that every single layer you deal with needs to be thought of and treated in the same respect as that banana skin, that is a good start. So let's look, for example, at the pig skin I had last week. And muscles, effectively, I've seldom cut. They're usually split. But you can see with each of these, there are layers, and each layer needs to be pulled together and closed, bearing in mind that banana skin. Each layer needs attention and closing to pull together, because the intention is primary healing with no space, because spaces in surgery are potential problems of infection. Imagine there's a space here, right underneath here. There's a huge space I've developed. That's a raw area for an exodus of protein and blood. And what is a blood agar plate in a path lab? But warm blood at 37 degrees collected in an area like that, perfect for infection. So you need to bring each layer together deliberately. Now, the other thing is, the most difficult incision, I think, to close is a thoracotomy, because everything moves and shifts, and you need to actually make sure it's aligned. Because posteriorly, if you get the layers wrong, not only have you got a lump that the patient has leaning against, but the skin itself won't come together. And the skin only comes together because you've paid attention to the detail. When closing deep tissue with a monofilament or any suture, come from inside out first, then outside in. And the reason for doing this is you need to ensure that your knot on a monofilament is buried. Many people actually lose a lot of weight after surgery, but it's amazing that a 7 throw proline knot can cause a patient a lot of aggravation because it's sticking up. And I commend you to come inside out, outside in, to actually close the layers so your knots are always buried and the patient is not sitting against the knot. And each layer is closed and the tension is maintained each time. You don't put 3 throws of the needle through the tissue and then drag it through, because you can see it is now strangulating. And a continuous suture is a strangulating stitch. It's the last thing you want in wound healing, is a stitch that's strangulating. With the subcutaneous tissue, as you see here and on the banana, sometimes it's very thick. You might identify campus fascia in the difference between cuboidal and longitudinal fat cells. And it's at that fascia layer that you put in a stitch. But I wouldn't recommend, in fact, that you put an over and over stitch. On the contrary, I would actually suggest in a fat layer to bring the fat layer together, and you're only bringing the fat layer together to close the space, because we said spaces are potential places for collection of blood and exudate. I would recommend that you use a horizontal mattress suture in all your fat layers, because this is not strangulating and is not hemostatic. If the tissue does not hold the suture, do not persist and go over and over again. Make sure that you close the tissue, and in these circumstances, I would always put a drain in. And if there's a potential space, I'd use a drain. And I'd also use a drain and leave it in for at least 72 hours to get over that inflammatory phase. Note as I'm putting this horizontal mattress suture in, I'm going 90 degrees across each side, and I'm taking the suture up gently each time. The same applies, and you pull it together and you tissue apposition. You have 90 degrees on the other side. So when it comes then to actually closing the skin, all the layers should be held together without any tension whatsoever, because you've chosen the right suture. But more importantly, as evidenced in the trials of closing abdomens, is not the suture that counts, it's the technique that counts. And that's why I bang on about it in the Black Belt Academy. So let me also then come to the skin. If there's any doubt about the wound healing clean, or if there's any question of there ever being any infection, I would actually close the wound with interrupted sutures, because I could take out the interrupted sutures and release, as they used to say, the evil vapors without letting the whole wound unzip. Hopefully that will not count. My favorite suture for closing the wound is monocrol. It's an absorbable suture, but it's a monofilament. And as I said, the knots of monofilament can be problematic. So when I close the skin, I don't knot this at the end. I put a hemostat on it, and I put a ligger clip on there and top and tail it at the end. Because I noted when closing sternotomies, if I tied this monofilament on the inside, what we know from microbiology, even though it's a monofilament, bacterial microfilms can form on it and cause a nidus of infection. So, to perfect my wound closing, I removed putting knots. Again, tying this together as the skin and the subcuticular suture. Remember, my forceps are not grabbing the tissues at all. Not grabbing the tissues at all. And I'm coming 90 degrees across each side. Imagine I'm making a little ladder. It's 1 centimeter apart. Some people use curved needles, but I think curved needles gives you that Walker's crinkle cut appearance because they pull it too hard. And if you're doing in the subcuticular level, 90 degrees across, 90 and to get it 90 degrees exactly, just come slightly backwards, because otherwise you'll get run ahead of yourself. And I pride myself with closing wounds, and particularly like closing wounds of people who've got tattoos on the chests. I've done a tiger, 12-masted, 3-masted schooner, and even done a Jesus Christ on the cross with 2 angels either side. And the wound looks so good, I use it in my lectures on wound healing. So the 90 degrees applies even for subcuticular stitches. And if you end up, and I've done that, if you end up with a bit that's sticking up high there, you can see that bit there, that's not good. That's not tissue apposition. And if you see that, please take a moment and take that stitch out and do it again, okay? Because this will actually affect healing altogether. So one last thing is what do you do about solid organs? And by way of example, I've got a tomato. Well, closing a liver, a spleen laceration, a lung laceration, or even putting a stitch in the heart. You can see there that that interrupted suture is going to cut out. In fact, proline cheese wires through tissues. So in this situation, I would use a horizontal mattress suture, but with a difference. The difference is a pledget. The pledget I'm using here is a bit of cut-off t-shirt. The pledget may be a bit of Teflon, but I had a patient with a persistent wound infection, and the plastic surgeons traced it all down to a bit of Teflon I used to close the heart. So I would suggest perhaps we should use autologous material, a bit of fascia, a bit of peritoneum, a bit of pericardium, but I'd use something like that to avoid an inflammatory reaction. And the horizontal mattress suture is pledgeted sutures are very good for solid organ tissues and ties, and certainly fixing VSDs after major infarcts in the heart or aneurysmectomies. It is important. Now, what's interesting about putting a stitch in a heart and a ventricle to close it? You do not actually tie it very tight. In fact, all you need to do is just bring it together gently. If you tie it tight, you're going to cause a problem. There you go, pledgeted suture. I'm going to bring it down. And bring it down. And sometimes it's extremely difficult. And the tomato, there you go, the tomato is difficult and it tears out. And that is how soggy tissues can be. And you have to be extremely careful at all stages to ensure that your technique is correct, you feel the tissue, and you. So I always felt it was very strange that everybody disappeared and let the most junior person close when they're just learning the basic skills. But if you attend to the basic skills, your wounds will look good. Two last things. Firstly, hemostasis happens at the beginning of the operation. Be meticulous going in and attend to the hemostasis. Don't get to the end of the operation and then try and dry it up. That's particularly true in cardiac surgery when we heparinize patients. Lastly, diathermy itself burns, cauterizes, fulgurates tissue. And I remember, because that's the way we've always done it around here, skin incision and then taking a cutting diathermy through everything else. And indeed, in somebody who's very fat, and there's 10 centimeters of fat, it used to spit and bubble and smoke as it went through all the fat. It was a bit like a deep fat fryer. But that's not good for the tissue because it's fulgurating and damaging the tissue. Fat does not bleed. Yes, there are lots of veins in fat, and you need to tie them off rather than burn them. But leave it fresh. Attend to the hemostasis, and the tissues will come together in beautiful layers, and you have the perfect balance between healing in the inflammatory phase and proliferative phase, as opposed to going the other way, getting granulation tissue and excess scarring and contractures. Lastly, do you put a dressing on? And the answer is yes, because nature's own dressing is the clot, because the new epidermal cells need to migrate in a moist environment underneath that clot to cover the wound. The other reason to put on a dressing is to stop the patient scratching. Itching is the mildest form of pain. And I saw a patient who had a nasty wound infection 6 weeks after an otherwise good operation, and he grew a bug in there that can only be found in the potting plants. of tomato plants. He did that. He was scratching his wound. If in doubt, use a drain. Drains and suction for 72 hours, suck it together. There are some fancy dressings out now, negative pressure dressings, put on wounds, and certainly in high-risk patients, they have a place. But why use such expensive technology in everybody when you haven't attended to the basics all the way through? That's why we've got the Black Belt Academy of Surgical Skills. Because in the end, it's all about getting the basics right, even at Black Belt. I hope this has made sense to you. I look forward to seeing you next week. Please do send in pictures of all your work, and we'll continue next week and revisit the knots, because as you see there this evening, I tied it too tight and it tore out the tomato. My friend Ashok set me that challenge. Thanks very much, Ashok. I'll do some more practice on my tomato before next week, like I hope you will do as well. Thank you very much for joining me. Good evening, good night, good afternoon, and thank you for following. Bye-bye.